everyone. On behalf of Association for Veterinary Dermatology India and Intas Pharmaceuticals, I invite all of you for our dermatology webinar, which is very important today. Skin is a mirror of internal organs. In our practice, we might have seen a lot of cases which will be having a skin issue, but later if you see, they'll go for a different issue, like that uremia or kidney issue or a liver issue. Like that, sometime even a distemper will be seen in the later time only. So it will be reflecting initially in the skin only. So like that, we have got very many diseases which we neglect in the early days itself. If you have suspicion, we can identify early. So to have this idea, we have a very good eminent speaker. Everyone knows about him. See, we are proud to invite Dr. Yathiraj, former Dean of Bangalore Veterinary College, for our show. And then I also invite Dr. Nitin and Ravindra Patel and Dr. Amanjot Singh for this coordination. I request Dr. Nitin Bhatia to introduce our speaker, guest speaker. Thank you.
Thank you, Dr. Nagraj sir. I don't feel that the current speaker needs any introduction. As skin is a mirror of animals' health, so is Dr. Yathiraj a mirror of our profession. So I welcome Dr. Yathiraj. Dr. Yathiraj is currently running his second innings as a private practitioner. But prior to this, he has been an eminent physician from Bangalore. He has been the former dean of Bangalore Veterinary College. He has been the director of research at Bidar Veterinary College. He is currently also on the advisory board of Karnataka Veterinary University. So and he is also associated currently with Commonwealth Association, as well as I know he is a president of IBA, that is Indian Biometrics Association, something which has been nurtured by him to promote large animal practice. Although I have always requested him to take it to all India, but that is something that is predominantly have been his efforts. So over to Dr. Nagraj for a good insight into the skin and the healthcare diseases associated with the skin. Thank you, sir.
Yeah, good evening, everybody. Good evening, Dr. Nagarajan Balasubramanian, the president of Association for Veterinary Dermatology India, and Dr. Nitin Bhatia from the Intas Pharmaceutical, who have been very good in terms of education and probably I would say a knowledge bank in the veterinary profession. And also Dr. Ravindra and Amanjot Singh from Intas, all the invitees who have been participating in this. So let me say thank you for all of you, and thank Nagarajan for giving me an opportunity, and thank Dr. Nitin Bhatia for the wonderful introduction, and again back to you and to talk about cutaneous manifestations of internal diseases in dogs. Let me move on and talk to you. The topic why we chose this is probably known to everybody today, like we need to be working on these, right? So let me go on to, and we can say that virtually all the internal diseases will eventually have a cutaneous manifestation, such as dull dry coat, which sheds easily and is not replaced at a normal rate. This is what finally of internal disease when we talk of. So systemic disease first and then a skin lesion. So these are a set of diseases, one kind of that. The second group, skin lesion first and then internal disease manifestation. And in this lecture for 1 hour, we will concentrate on this, meaning to say the skin lesion which have an internal component as a disease. What are these cutaneous manifestations? Primarily hormonal disorders, hypothyroidism, Sertoli cell tumor, Cushing syndrome or the hyperadrenocorticism, sex hormone responsive skin disorders, particularly the testosterone responsive dermatosis, estrogen responsive dermatosis. Then comes the major group of the metabolic disorders, and very specifically metabolic disturbances in zinc leading on to zinc responsive dermatosis, lipid metabolism, leads on to cutaneous xanthomas. The third category in the metabolic disorder being the increased amino acid catabolism, which is referred to as SND, the superficial necrolytic dermatitis. Then immune-mediated systemic diseases, particularly the lupus, both DLE and SLE, atopy, which I will not concentrate too much because there have been too many lectures on atopy, nutritional disorders, which are related to vitamin E and vitamin E, neurological disorders, particularly the multiple collagenous novi seen in the German Shepherd dog, which we'll talk about, predominantly asymptomatic firm bumps in the skin, and which are all invariably due to the renal or uterine tumor. Neoplastic and paraneoplastic disorders, which are specifically very common in case of cats, not in dogs. And certain of the infectious diseases predominantly can in distemper, which produces probably pustules, ICH bar leptospira bar pig fever, which produces jaundice and petechiae, generalized dermaphytosis, etc. Goes on like that. So these are the areas which we will probably talk and share a few of my observations on this. Before we go on to that, first thing that I would like to mention here is what is the dog skin versus the human skin. Reason being, lot many of us, lot many people, even a human dermatologist will always say that they have the best of the practice and what is good for a human being is good for the dog. It's not so. Imagine the pH of the dog skin is 7.5 and the human skin is 5.5. The dog skin is 3 to 5 layers, whereas the human skin is 10 to 15 layers. People talk of dogs and vets as thick skin, and humans as very sensitive. But here it makes a difference for us. Our animals are thin-skinned and we are thick-skinned. The hair growth is cyclical in case of dogs, whereas it is continuous in case of human beings. Sweat glands, general statement absent, except the foot pad and the muzzle where it is present, whereas in humans, present all over the body. What are the diagnostic techniques, irrespective of what we talk of, whether I talk of cutaneous manifestations or a general way? The basic thing that revolves is history. Thorough history is very important. Physical examination to rule out many of them, because to come at any kind of a disease, the basics have to be taught of. The basics have to be ruled, like ticks, fleas, flea dirt, pinna-pedal reflex, dander, rough hair coat, alopecia, dry bar, wet lesion, etc. Pattern and distribution of the lesions, skin scraping examination, cytology. These are all very important for us, like impression smears, roll-on smears, fine needle aspirates. These are all very necessary and good diagnostic tools for a diagnosis, but primarily a differential diagnosis, because there's a big list of differential diagnostic diseases to be made before we come to a primary diagnosis. Examination of the hair would involve the wood slam, culture and the sensitivity, skin biopsy. For these you get the biopsy sets these days, sets of allergic skin tests, blood and biochemical tests, particularly for enzymes, cortisol estimation, hormone estimation, ultrasound, very specifically for the liver, spleen, etc., specifically in the diagnosis of, probably you can say, the SND, what I talked about. Ultrasound is also necessary in hyperadrenocorticism. MRI would be of use in probably ovarian tumors, ovarian cysts, as well as in case of splenic enlargement, liver enlargement, etc., which all contribute for a dermatological disorder. Tools for the dermatology work: a good room, well lighted, table, white cloth or a paper on the table, restraint tools, very important, BP blade, scalpel with sharp cutting edge, glass plate, cover slip, paraffin, KOH, microscope, all these, everyone knows. I'm just making a mention of that. Stain, either the Giemsa stain, gram stain, lactophenol, cotton blue stain, etc. Cedarwood oil, allergens, hair clipper, graduated syringes, sterile swabs, disposable syringe with needle, etc. Now let me come back to the cutaneous lesions, what we see in specifically what the topic that we are talking about. The topic what we are talking today is the cutaneous manifestations of internal disease. What is that kind of a cutaneous lesion? What makes you as a dermatologist to think that this could be an internal disease? Dull dry coat, which had easily, and it is not replayed at the normal rate. When I say this, the history will tell us that the growth of the hair is very, very slow. crusting, erythema, exudation and alopecia peri-orally and peri-ocularly around the genitals and the distal extremities, hyperkeratosis, ulceration of the foot pads, thickening of the hair coat and skin, thinning of skin, sparsing of the hair, discoloration of the hair, inter and intracellular edema limited to the upper half of the epidermis where it might appear like red, white and blue, nodules as you see in cases of nodular dermatofibrosis syndrome in GRDs, ulceration of foot pads, discoloration of hair by the skin which could be because of the environmental allergy or the atopy, flea allergy, food allergy, parasitic infections, bacterial infections caused by pyoderma, yeast infections specifically or the malassezia. Now let me just look at these kind of lesions, what will make you think that these are different. This is exudation, crusting, alopecia. What I talked about all those lesions, let me first show these lesions, then let us look at whether they are the cutaneous manifestations of an internal disease. In this case of it, probably you can make out the crusting, the alopecia, exudation, what's happening, whether it is a primary pyoderma or it is something else. It's a manifestation of an internal disease. The crust, the dull dry coat and the lymph node enlargement, what you see them here, you can make out the lymph node enlargement in this. Exudations, as you see, this is the tail area, what you will see them as the moist eczema sometimes. And you see the lesions of malassezia and pyoderma, like the red lesions, the central colorate and thickening of the skin, etc. Thin skin and sparse hair, what you can see them, as you can make out the brown, the totally changing into this, and in this kind of cases a totally different way, very less hair on this. And you will find hyperkeratosis or thickening of the skin. You can make out even the skin folds in these areas of this. Again, the blackening of all these areas of that. Severe hyperkeratosis in all these, even the wrinkles being formed on this, even here. Discoloration of the hair from the black coloration to the brown discoloration, which could be because of the deficiencies or it could be primarily a different phenomenon altogether. Atopy, not many photographs to show you how the redness of all this can occur. Let me leave this because enough has been talked about atopy. Certain times of these cutaneous lesions, what you see them as not primary lesions. It is an immune-mediated way and you will see the lesions in the skin. Jaundice in the skin area as well as the eye. Pustules as to what you see in cases of distemper cases in the lower abdomen in a male puppy. This could be impetigo, this could be pustule. Similarly, you get even in case of distemper where you find the vesicles of this. Periocular and perioral involvement, you can see the lesions of this, which I'll show you more little later. Now let's come to, these are the manifestations. Incidence of the skin diseases in dogs. It varies from country to country, but overall, generally, based on very many reports, you can say 25 to 32% of the cases are dermatological disorders. Probably you can very well say this is next to the GI disorder. And of these, what we are talking today in the dermatological disorders, what I am going to concentrate today is in these, the hormonal, metabolic, nutritional, immune-mediated deficiencies. This contributes to the extent of around 10%. That means out of this 30%, 1/3 of the practice revolves around the disorder that we are going to talk today. And that's the reason why we need to be thorough on the skin disorders. Let us start first with the hyperthyroidism. The history of the cases like lethargy, obesity. We all know obesity by itself is a disease, but the animal is putting on too much of a weight, and we all need to know the standards when we talk obesity. The breeds which are very prone are Labrador, Setter, German Shepherd, etc., etc. So one needs to know the standard adult weight of these dogs. Starting from a Labrador, a Golden Retriever, when we talk of 35 kilos, for a German Shepherd around 32 to 35 kilos, and Golden Retriever again 35 kilos. And each breeder had a cocker spaniel between 10 to 12 kilos and the larger up to 15 kilos. Now when you talk of the obesity to what level, I'll show you some of the photographs later wherein we have seen cases of Labradors weighing 45 kilos, 50 kilos, 60 kilos like that. Intolerance to the cold, they would like to seek sunlight and keep going. Abnormal estrous cycle or lack of libido in the male, very common. Like normally we all know that the females need to cycle anything between 6 to 9 months. Sometimes we talk of 2 cycles in a year, or at least 6 to 9 months one cycle. If the dog doesn't come and cycle, the female dog for a year and a half or a year after the regular cycle, one of the things to be suspected is hypothyroidism, variable appetite and muscle weakness. These are the manifestations. This gives you a clue to say, yes, this could be a case of hypothyroidism. Hair loss, patchy initially, but eventually bilaterally symmetrical. Pruritus, generally hormonal disorders, we always talk in terms of no pruritus. But invariably, these kind of hormonal disorders are with secondary bacterial infection. So the moment there is a secondary bacterial infection, like pyoderma, or a secondary infection of the yeast, the itching starts. So all the time one cannot go by no pruritus. So you need to be really thinking about this. What is the way? Bilaterally symmetrical non-pruritic alopecia which spares head and extremities. When we talk of bilaterally symmetrical, you will see the left side, you will see the same thing on the right side. This is what we meaning of bilaterally symmetrical. So bilaterally symmetrical lesions would mimic in probably hypothyroidism, even in Sertoli cell tumor, in Cushing's, etc. Then how do we differentiate? Probably as we continue with the ractile appearance in case of hypothyroidism, hyperpigmentation, what we saw earlier, thick skin, coat down, and easily epilated. Hair shedding is very severe. Seborrhea, and then comedones, particularly over the dorsum. Comedones can be seen in many other ways of that. Once you suspect, what is that we're going to do? The simplest that we talk about is cholesterol levels. Hypercholesterolemia is the first sign, but it's always not true. If it is associated with the symptom that we talked about, and there is an elevation in the cholesterol level, that again gives an indication that it could be a possibility. But what is more important is estimation of thyroxine, T4, combination of T4 and FT4 and TSH, T3 and FT3. I will take a minute and talk to you a little more on this because every one of us are used to sending the samples, if you don't have your in-house laboratory, to a human laboratory. Majority of the human laboratories use the human standards, and in all of the cases of that, all of the biochemical parameters, the human standards hold good, but for thyroid profile, the human standards do not hold good. Please underline this. So if you're getting your thyroid profile done by a human laboratory, ensure that they use the animal standards. If the animal standards are not being used, your interpretation of the results becomes false. You make a wrong diagnosis. I would rather recommend saying that please evaluate, get it checked from the laboratory as to whether they're using the animal standards. If the animal standards are not being used, there is no point in spending money on the thyroid profile because thyroid profiles are expensive and it doesn't take you anywhere to make a diagnosis. These are the normal values for the dogs like T3, FT3, T4, FT4 and TSH. You need to make a combination of these because T3 and FT3 both are important for us. And similarly, T4 and FT4 are important. So TSH is just an indicator of this. You need to use these as the standard values and then compare and work on them after you get your values and then accordingly start the medication on that. Look at this Labrador, like such a huge dog, and the opacity was the only criteria, and later it's developed into the typical hypothyroidism or period and that. This is a cocker spaniel. Rarely it can be a situation wherein you find only the lesions, bilaterally symmetrical lesions all over here, and certain areas of the dorsum, it is the same photograph which I'll show you, and you can see the alopecia in both the sides of these areas. This is, look at this dorsum very specifically. It's like a buffalo skin, wrinkles have occurred. And here you can see certain points which you refer to as the comedones and even seboria, very sticky and probably smelly as well. This is the typical reptile, and this is an eye setter, hollow, the dorsal area, the whole, and then even very perineal area where the hair loss has occurred, and as you go closer you can make out here the sparsing of the hair. You can probably look at the skin itself. This is an iris setter, this is supposed to be a hairy breed, and you can imagine. This is an Labrador, you can make out the reptile appearance of this. These are good enough to say. Mixed edema is very rare. This is the swelling of the area which is occurring on this, and it's not a very common finding. Treatment of hyperthyroidism, I think again we need to really work on this. The recommended dosage of this is 20 microgram per kg twice daily for 6 weeks and 20 microgram per kg daily, and probably there are many preparations available. Not many people start on 10 to 20 microgram per kg. Good enough onto this. You have all kinds of preparations, plenty of the preparations available at 50 mg, 100 microgram, 50 microgram, and treat for a minimum period of 6 weeks. The treatment regimen in case of humans versus animals are different. Many times it becomes a frustrating thing because many of the human owners or the pet owners come back and say, we take one tablet, I'm 60 kilos. Whereas I have a 45 kg dog or a 40 kg dog, we start recommending 4 tablets twice daily or 3 tablets twice daily. It becomes very difficult for us. Next, let's move on to sertoli cell tumor. The breeds which are susceptible for these are the Boxer, the German Shepherd, the Afghan Hound, Weimaraner, Collie and Maltese. This is a non-pruritic alopecia, non-pruritic hyperpigmentation, enlarged nipples by the mammary glands, palpable mass in the testicle, but may not be always. If you find all these and you still don't find a mass in the testicle, still you should consider sertoli cell tumor. Pendulous prepuce, and if you do an hematology, you will come across thrombocytopenia and anemia. These are the features of this. These are the dogs that can go into this, both. Whether you call a retention of one testis or both the testes, retention of testes they are more prone for, number one. Even both the testicles being outside, they can go in for it. What makes it is difficult to say. And it starts producing, this is a tumor, different kinds of tumor can occur in this, like the cells of them start producing the estrogen. So the effect what you find is because of estrogen. So there are reports of quantitation of estrogen being higher, being normal. Still symptoms can occur always. So cannot always go by only hormone estimation, need to go by the physical appearance of these lesions and these. Let me show you some photographs other than working on that. Look at this is a German Shepherd, and you can make out the enlargement of the nipple in a male dog. This is the preputial area, hyperpigmentations have occurred, hair loss has occurred in all these areas of these. And similarly, into the adult, this can occur in any age of the dog, normally between 4 to 6 years, sometimes beyond 8 years. And now you can make out prominence of the nipples, enlargement of them. Certain times you do even find secretions of the teeth. You can also see the pendulous prepuce. Hyperpigmentation has occurred in this area as well as in the groin area. You could also see the lesions in the skin where there is sparsing of the hair as well as the dander coming out on that. These are typical of that. Yet another, you could also see bilaterally symmetrical lesion of this. You can make out. So everything is covered here. And again a case of sertoli cell tumor. Let me go back to the previous. The treatment part of the sertoli cell tumor is number one, neutering or the castration. For any reason, the one which is retained inside, you also need to remove the one which is retained in the abdomen. Once you do that, normally it takes about 3 to 6 months for the hormone to reverse. And during this period, apart from the neutering or the castration, exogenous sources of testosterone might be necessary to be given. And the standard procedure is use of 1 to 2 milligram per kg body weight of testosterone at monthly intervals, or you could also use oral preparations, again at the same rate of 1 to 2 mg per kg, which I'll talk to you a little later, and can put them on, and you would see a response generally in about 2 to 3 months, not earlier to that. Need to take care of that. The third most prominent of late is hyperadrenocorticism. These are the cases which will come and tell us, look at me, I'm having hyperadrenocorticism. Look at the frontal alopecia, totally, the muscle wasting, pot belly appearance, which we'll see some more photographs of them. Look at them. Again, hyperpigmentation of this and thinning of the skin in this situation of this. And you'll find easily bruised areas of this, which like the typical hemorrhage. But anybody, if you look at this, might look like hyperpigmentation, and one might say, look, this appears to me as a case of melasthesia. Yes, this is a secondary infection of melasthesia, or this is a hyperpigmentation because of the hormonal disorder. Both need to be worked out on this. All these cases of them have a secondary bacterial infection, secondary yeast infection. And these are of late cases are increasing. The causes of hyperadrenocorticism could be exogenous administration of corticosteroids for a longer period, as seen in cases of atopy, or use of indiscriminate use of corticosteroids, which can lead to iatrogenic hyperadrenocorticism is pretty common, or it could be because of the tumor. So when we talk of these, when we say hyperadrenocorticism, go by the clinical signs, skin changes, hematology, biochemistry, that is increased cholesterol level, increased alkaline phosphatase, lipemia, decreased blood. These are only symptoms to suggest that. But what is more important is, you would also find urine specific gravity to be less than 1.015, glycosuria in some cases, and then invariably urinary tract infection. That is because of an increase in the cortisol levels of that. But these are the problem that you will face here will be ADH and PDH. Pituitary dependent hyperadrenocorticism versus adrenal hypercorticism. In both the cases, there could be a tumor in these. So the diagnostic test for this would be estimation of cortisol, urinary corticoids, plasma ACTH concentration, ACTH stimulation test, wherein you talk of low dose dexamethasone suppression test, high dose dexamethasone suppression test, and urinary corticoid and creatinine ratios. All these need to be got done. And for these low dose method tests, you would inject the ACTH followed by the dexamethasone, and then quantitate the cortisol and go ahead with the test. But as a practitioner, everybody is not doing it. This is rewarding more in the multi-speciality hospitals or in the institutions of that. And now, when it comes to the treatment part of it, if it is adrenal dependent, and adrenal dependent, when you talk of hyperadrenocorticism, could be diagnosed by ultrasonography many a times. Ultrasound would definitely help us, and you can go and visualize the blood vessels and trace the adrenal gland. And if it is a surgery, it can be done. That's the best way. If it is ADH, PDH, no surgery. And then the question here is the treatment part of it. Nicotine not being used these days, but ketoconazole has an effect. L-deprimerol, cyproheptadine, but more common these days is the trilostane, which is used and irradiations are done. And in these ADH, dogs diagnosed having ADH carry the best prognosis if the tumor can be removed surgically, although Vitotin therapy may also be tried in these cases of this. These are all the treatments of these cases of them. You can make out the pot belly appearance. You can see so much of blood vessels being prominent on these thinning of the skin and a whole lot of alopecia in this. And the same cases of them. You can see a set of cases after treatment with trilostane. This is a terrier, see this, and this is the treatment period going on. This is a poodle, you can see them, and these drugs are much better. These are available in the market. Similar cases of prior to treatment and after treatment. 20 of them, you can see typical cases of pot belly appearance. You would find lesions like this, particularly in hyperedenocorticism. The neck arc disappears like pyoderma to anybody, and these kind of cases would need, apart from the primary medication, this also needs the antibiotic treatment, secondary medication to prevent the pruritus to some extent. In this case, there is pruritus, but be cautious. You are treating a case of hyperedenocorticism. As such, the cortisol levels are higher. Don't ever think of using corticosteroids in these cases. If you do that, you are aggravating the situation and it will become fatal. Plenty of cases as time goes on, you will see all these. Now let me move on to the metabolic disorder after the hormonal disorders. The first of its kind is the metabolic disorder, the zinc responsive dermatitis. It is a keratinization disorder. The breeds are husky and malamutes are the most common breeds. The lesions you see are reddened skin, hair loss, crusting, scaling around the mouth, chin, eyes, ears, foot pad and scrotum. And invariably, even in these cases, you have the bacteria, the fungi and the yeast. So many times our treatment, apart from the routine medication, also revolves around the treatment of bacteria, fungi, bodies. It meaning to say, we are treating pyoderma, we are treating malassezia, we are treating dermatophytosis. So all these become common in that. In these, when we talk of these, there are three kinds of zinc responsive dermatosis being taught. Type 1, very common in case of Doberman and Great Dane. In these, the diet has an adequate zinc, but conditions like the environment, excess of heat, high temperature, gastrointestinal disorders, they lead to inadequate intestinal absorption. What makes it? Question mark. The zinc that you are giving is not absorbed by the intestines, hence there is a deficiency. So this is what we call type 1 zinc responsive dermatosis. Type 2, again very common in the giant breeds, more particularly Great Dane, German Shepherd, Labrador, Doberman, Poodle, etc. This is directly related to the dietary supplements. Of late, probably you know very well, not many breeders have a feeling that I use a diet, number one. Then I start using excess, lots and lots of calcium, and also start thinking of using many supplements which might have a phytate. What these do is, these chelate and they interfere in the zinc absorption. When they interfere in the zinc absorption, the zinc deficiency would occur, and that's what we call them as the type 2 zinc responsive dermatosis. Now the third category, these are called zinc responsive dermatosis, referred to as generic food disease. These are dogs eating dog foods that do not meet the NRC nutritional requirements, claim but they do not contain number one. Even if they contain the zinc, they are poorly bioavailable. Giving any form of zinc is no use. It should be a good bioavailable zinc that you should incorporate, which I'll talk to you in the treatment part of it. So you have three categories of them, type 1, type 2 and type 3. Let us look at some photographs on these. Look at this husky, need not be bilateral. Many of times, people talk of spectacle appearance always. No. Right eye is paid, only the left eye. You can make out, this is a zinc responsive dermatosis. Look at the lesions, periocular. What all we defined earlier, alopecia, exudation, crusting, erythema, all are present here. Keep going, you can see the chin area. This is the perioral area. And then this is the elbow area. Many times we start thinking of this is a fungal infection, it's a bacterial infection. You can see the pad as well. All over there is such a severe bacterial infection. There is hyperkeratosis, crust being formed. Imagine any amount of medication without a zinc supplementation to these cases becomes useless in that. This is bilateral. Again, in husky, you can see the lesions on that. And secondary infections. This is the nasal area. You will find across this. Many times people talk in terms of solar dermatitis. They are different. Solar dermatitis is different from these kind of lesions around the mouth, which is totally different. Again, in expanded way, you can see the thickening, oozing, eruptions like material exudations, all that, all that. And again, look at this periocular lesion, typical. Any amount of medication of antifungal, antibiotic and changing from drug to drug. Again, look at this. Left eye is fine, right? Unilateral. Periocular lesions are the primary in the zinc response to dermatosis. So what is that we do? It could also lead on to a crack in leg in certain of them. You can see these areas. This is again a zinc deficiency. Treatment part of it. There are basically three compounds available to us. Use them. One is the zinc sulfate, zinc methionine, and zinc gluconate. Not many people would take zinc oxide. Zinc oxide is easily available if you normally use in the ointment, where we use them as probably an antiseptic cream. There, zinc, that kind of zinc. You use zinc sulfate, not zinc oxide. Zinc methionine and zinc gluconate. Zinc sulfate 10 mg per kg once daily. Zinc methionine 1.7 mg per kg. The biology is fantastic in this. The best part being zinc gluconate 1.5 mg per kg per day. Next comes the duration of treatment and response. This is the point to be decided. How long? You cannot just give it for probably 3 weeks and stop it, or 1 week and stop it. The levels have to be monitored. Unfortunately, zinc level quantitation is not a good guide in the monitoring of these patients. So many times the skin biopsies have to be done for diagnosis as well as for monitoring. So as clinicians, what is that we do? Remission of the lesions and hair growth, and lesions do not occur again. For any reason they show the initial symptom, put them back onto that and monitor the levels of the zinc in their diet. That's more important. You can do that, you have a good success rate of that. The second categories are xanthomas. This is a tan yellow vascular nodular mass. It can occur on the skin, it can occur on anywhere. Xanthoma meaning yellow lesion. This is on the eye. You can look at this kind of lesions. You will find similar structure sometimes even in the skin. And this is again because of a derangement in the lipid metabolism. Question mark as to how it occurs and what makes it. You will find plenty of these tissues on there. The only methodology for this is surgical intervention is the only method of treatment for this. And there are occasions where it can occur again and again. Check the source of that. This is a post-surgery xanthoma. You can see the vascularization and the whole lot being removed on that. The most important is the third, is the metabolic epidermal necrosis or superficial necrolytic dermatitis, also referred as the SND. It's also called as the hepatocutaneous syndrome. It's a syndrome, and these cutaneous lesions mimic the pemphigus foliaceus. Also, they do the systemic lupus erythematosus. Prognosis in these cases are very poor. How do they look like? Crusting, erythema, exudation, alopecia. Lesions are seen periorally, periocularly, around the genitals and distal extremities, hyperkeratosis and ulceration of the foot pads. Look so bad, you can look at them. Persistent hypoaminoacidemia, amino acid, and persistent elevation of glucagon may be responsible for hepatic changes that occur. So this is one which causes, and this has been evidenced by the serum concentrations of amino acids, particularly hydroxyproline, threonine, glutamine, proline, alanine, citrulline, arginine. These are all severely reduced, and their metabolism is what is going to cause this, and these are the kind of lesions what you get. Look at this kind of lesion in the foot. So everyone, this more looks like probably the fungal infection with pyoderma. You could also see the nail bed infection, oozing. Very ocular lesions which would occur all around here and even around the mouth. You can see that. In addition, look at this hyperkeratosis of the foot pads. I'm sure everybody in a day in day out will see such kind of cases. We all put them as fungal infections because you can look at this kind of lesions on that. It could also be in the elbow, particularly what I showed earlier in zinc versus this, with a red kind of a lesion what you see on them. What is being talked for the treatment for this is, you know very well that we talk in terms of the liver and glucagon levels of this. And when we talk of the treatment part of it, the primary treatment should be infusion of amino acids. And you get the amino acid preparations and look at them. 6 to 80 mg per kg intravenously daily for 3 to 5 days initially, and as and when necessary over a period of 3 to 6 weeks if they don't respond. And primarily look at all these kind of lesions as to whether it is there in the liver or even the spleen is being involved, liver is being involved, and accordingly the treatment for it. Antibiotic of again choice you need to make. Vitamin supplementations are necessary. You need to build the animal's immune status as well. Again, the lesions are that same way. Immune-mediated skin diseases, other category. In this, we will have two of them. One is the discoid lupus erythematosus, which affects the face, nose, lips, mouth, ears, and eyes. Rarely feet and genitals. Pale skin on the bridge of the nose, redness of the nose, redness of lips, face, etc. And sores and ulcers would occur. On the contrary, when you talk in terms of a little more of them, fever, ulcers at the mucocutaneous junction, enlarged lymph node, enlarged spleen, enlarged liver, muscle atrophy, all these, in all these cases of VSLE, and the prognosis is God. Look at this kind of lesions, immune-mediated DLE, both eyes being involved, bridge of the nose, you can see the ulcerations, all these. And this is in a St. Bernard, all these around the eye being involved. And this is again the same animal after treatment. This was presented to us in the hospital here. And these photographs are after about 3 months. And the set of medications that would go here are, and probably the medication that we need to think about in these kind of cases are supplementations. Again, immunosuppressive compounds being used like prednisolone. We can talk about being used over a period, supplementation with vitamin E very specifically, and antibiotic of choice, whatever is regularly being used for the routine treatment can be thought of in this as well. Now the other simultaneously what you come across is the deep pyoderma, then the superficial folliculitis cases like these. All these you do come across wherein you need, these are the worst of the cases anybody would think saying that these are internal manifestations. Look at the kind of thickness what you got. It's a melancholia case, but it appears like an internal manifestation, but it is not. It's a primary melancholia. Yet another case of melancholia, but they all give you an impression like bilaterally symmetrical lesion. That's why I put them. You need to differentiate them. How do we differentiate these kind of cases? Skin scraping examination. When you do the skin scraping examination, you can identify these melancholia in any kind of a smear that you make. A routine skin impression smear, a tape smear, staying with genes, that's good enough to identify the melancholia organisms. Again, these are cutaneous manifestations as to where we can talk about them. This is the acrylic dermatitis, internal disorder, behavioral issue, or progestins being talked about it. Acrylic dermatitis, granuloma, all can occur. Etiology becomes question mark on this. Flank sucking, again a behavioral issue, an internal disease, and you will find hyperpigmentation, even lichenification, moist area of the animal starts sucking as if they are going to suckle a mammary gland. Acanthosis nigricans, very common in case of dachshunds. You can see the thickening of the skin on that, excoriations, redness, wetness, pigmentations, smelly thing, and secondary bacterial infection with yeast infections. What is causing? Question mark. Associated with hyperthyroidism? Yes. Seen in all breeds? Not all breeds. Very specific in case of infections. And treatment for this, supportive treatment, primary medication. Primary medication, question mark. But many people treat them with thyroid desiccates, do respond. Supplemented with corticosteroids, yes, they do respond. Treatment and recurrence will be there to manage that. Scaling disorders are all because of essential fatty acid deficiencies. These again need to be differentiated from Chiratiella. Do a skin scraping, you can do that. Lot of them in this. You will find them in Irish Setter, Cocker Spaniel, and Dachshunds very commonly. And in these kind of cases, scaling disorders, supplementation is important. You can supplement them with omega fatty acids, polyunsaturated fatty acids, more specifically omega 3, and right proportion of omega 3 and 6, would be the order of the day in management of these cases of this. In addition to these, we also have the other conditions when we talk of estrogen responsive dermatosis. Where do you find these kind of dermatological disorders, also referred to as the sex hormone related dermatosis? This can happen in female dogs when they are neutered at a very early age. Symptoms we find are leaky bladder and leaky vagina, people talk of repeated urination, and you could also find the lesions around the inguinal area as well as in the lower abdomen particularly. In such cases, diethyl silvestrol and of late other preparations, 0.02 milligram per kg, maximum 1 mg every 24 hours. Duration of treatment 14 to 21 days. Sometimes even 5-day treatment is good enough. Sometimes you need to do it when the symptoms are occurring. It can maintain a good dosage very well. Sometimes it can be a longer period than that. So monitor them based on the response index. Yet another is testosterone responsive dermatosis. Again, these are cases when the male dogs have been neutered in the early phase. Not that it's a good number of cases to get into that, so some small number of the cases. But why do you talk to them as is? They end up as if there is a hormonal problem, because we do find bilaterally symmetrical lesions on them, lichenification around that area, particularly pituitary area and groin area, and they don't respond. And history would tell us, and if you go in for the treatment, supplement them with a neutral testosterone at 0.5 to 1 mg per kg orally every 24 hours, not 28 hours, every 24 hours. And you need to do it for a period of 1 to 3 months depending on the response. You could also use the injections of the rate of 2 mg per kg every month. Again, it would take about this. All these cases, what would happen is they would take a minimum of around 3 months, very much similar to when we talked about a surface edema. Those cases, they will take 3 to 6 months, and the hair growth would start only after 3 months, not earlier to that. Many times we think we did the surgery and next month it's going to become alright. No, it could be as long as 6 months. Similarly, when you start the medication here, the response what you get is only after a month or 2, so you need to have a lot of patience on these kind of cases. Now, to summarize the whole lot of these, early detection of the problem by proper examination or investigation is necessary in these cases, because not many cases can mimic the symptoms of that, and to suspect them as an internal disorder and appropriately do a diagnosis and start the treatment towards that is more important. Second point that we need to worry about is appropriate medication or surgery which should go on. When we talk of appropriate medication, select the right medication and that. All kinds of cases are not just cases of atrophy when we start off corticosteroid treatment for that, and you might end up in hyperretinal corticosteroid. Surgery, wherever necessary, particularly insert early cell tumor, we need to go in for that. Ovarian imbalance, particularly ovarian cyst or hyperestrogenism when we talk of different disorders. Duration of therapy and patience are the most important things in the treatment of all these cutaneous disorders, more particularly which are of internal disease. We need to really work on this and monitor them. And certain times atopy can get aggravated in many situations of them. Avoid the allergens because the cutaneous manifestations are aggravated by allergens. Hypothyroidism allergy go together, Cochin's and allergy go together, and work towards building a good immunity for the skin. Because certain other things necessary to mediate or modulate, because there are certain of the disease conditions like DLE, atopy, they are all because of low immunity, and you can build immunity. Dietary management also become a part because certain times you need to change the dietary pattern or modify the dietary pattern in terms of supplementation with PUFA, supplementation with zinc, supplementation of appropriate levels of vitamins, and unnecessarily do not use large quantities of calcium in the diet because calcium leads on to a zinc deficiency. Calcium, when they lead on to that, many a times you also do get changes, particularly the deviations of the carpal joint, and that obviously can happen if you do that. So these are the take-home messages, and thank you very much for listening to me. Quickly I'll go through because many people will have questions to ask me, because quickly like what is the antibiotic that is of the choice in the treatment of pyoderma, because we are correlating very well with many cases. We need to put them onto that. You have the choice like cephalaxin, cefadroxil, acetic acid, ampicillin, amoxicillin, all these, amoxi plus clavulanic acid, erythromycin, lincomycin, clindamycin, tylosin, oxacillin, and then trimetazine sulfa, enrofloxacin, marbofloxacin, difloxacin, orgifloxacin, cifabacin of late, and mipirocin locum. So these are the combinations that you have. These are the specific drugs that you have. Duration of the treatment is very, very important. And then glucocorticoids are being used. Take care of them and do not use glucocorticoids in these kind of all the kinds of cases, because what many people think, any pruritus I can think of glucocorticoids, whether topical or systemic. Where to use them? To use them, not to use them. Please take care of that. Topical products plenty are available. Let me not talk too much about this. Let me go on to the word about atopy, because I did not give you photographs of atopy, because many a times atopy appears like bilateral lesions. All these, look at them, bilateral lesions here, and they are not primary. This is again a bilateral lesion of them. These are all seen in atopy. And use these, particularly fatty acids, are good enough to use them, and these are beneficial in about 10 to 20% of the cases. These modify and reduction of the inflammatory proglastins in the prostaglandins in the skin. They are good enough, better than a routine drug that we talk of. Fatty acids have a synergistic effect, and it becomes combined with a specific modification on that. These are all the methodologies which I don't want to talk on that, and histamines play a role. Topical therapies are available, like tacrolimus can be used very well. Many times not necessary that all the time one need to think in terms of prednisolone alone, because all the time using prednisolone has become a fashion and we end up in Cushing's. Tacrolimus are available. You can use the tacrolimus, you get the liquid, you get the ointment. Where you find them to be minimal way, you can modify them. Systemic glucocorticoids, immunomodulators can be used wherever necessary in this kind of. All these new combinations have come for the management of that, can be used on that. And these are all the new ways one can modify in this way. Now that we end with us back again, and let me come back and say to the last slide and say thank you for your patient hearing and the time given to me. And if there are any questions, I will be happy to answer them. Thank you very much. Hello.
Hello.
Yeah, I'll minimize that presentation.
Yes,
Come
sir.
back to.
Sir, thank you for a marathon run into internal diseases and its reflection into skin.
Yes.
We have a few questions coming up, and few questions are already there, so I'll pose a few of them before you.
Yeah. Okay. I'm just getting connected again. I don't know. Did I lose the connection? No, I'm on the connection.
Yes, sir, you are there.
Yeah. But I'm not able to see your chat. It says connecting. I don't know why it went for connection.
No, we'll put it across to you, no problem.
Yeah.
Sir, the first question put up by one of the vets is, I think he's a practicing vet.
Yeah.
He says when to use ivermectin parenteral and when to use ivermectin oral.
See, the question here is, the oral medications are necessary when you think in terms of a long-standing medication, what you want to do on the ivermectin. The purpose for which, the purpose for which you are using ivermectin, the criteria. Whether you want to treat a case of, say, dermatitis, a sarcoptic vein, and people start using ivermectin for ticks, fleas, etc., etc. So knowing the half-life of these drugs, you can think if I want, for example, some people would say I want an injection to be given for a tick. You can very well use a systemic preparation with an injection. And if you want, particularly sarcoptic veins and dermatitis where you want the medication to be done on a daily basis, people talk of oral medications after that. Otherwise, oral medications, I for one would say minimum use of oral medication, because it gets into the hands of everybody and people start using ivermectin for every case, like an antihistamine. I've seen people getting bundles and bundles of ivermectin tablet to me and say it doesn't work. Reason being they start abusing the medicine. So to avoid the abuse of the medicine, I think parenteral is the best. and where you need them for a long-term therapy in the management of mange, you can use statins.
Right, sir.
Yeah.
So the next question is on the fatty acids that you talked about. So should fatty acids be used as a regular tonic, or should they be used only in a dermatological affection?
See, there are two ways of using the fatty acids. When you talk of polyunsaturated fatty acids, when we talk of N3 versus N6, the specific combination, N3 is good enough, and N6, when we talk of, see, mechanism they work is the inflammatory process on the skin will release large quantities of prostaglandins. Prostaglandins, when they go into the cycle, are pruritus inducers. So if you want to suppress that kind of a pruritus, one of the method to use is the PUFAs, or the essential fatty acids. So what they do is they convert arachidonic acid cycle, what is going to go on. I didn't want to explain further and I just broke that. They take a pathway wherein you get prostaglandin E, and these are non-pruritic. So they break the cycle of pruritus. So in many of the dermatological disorders, the biggest problem that you face is the pruritus. So if you don't want the pruritus, the effect what you get here is the event what.
Sir, could you please elaborate on the overuse of calcium oral preparation that you talked about?
Yes. Yeah. See, the use of calcium, when we talk of this, the dogs which are maintained on a homemade diet versus a commercial diet, let me put it like that. If they are put on a homemade diet, the growth period, the requirement of the calcium would vary in the puppyhood, growth period, pregnancy and lactation. If anything varies between 150 milligram per kg to 350 milligram per kg. So one need to calculate which are the good sources of calcium. Unfortunately, what's happening in the current day is like people go in for a commercial diet which has a calcium and phosphorus and vitamin D balanced. And when we start using calcium tonics orally, you are giving excess of calcium. So excess of calcium would lead as an interplay to a deficiency of the zinc. That's one. Zinc deficiencies which lead on to the zinc responsive dermatosis, what I talked about. The second phenomenon of calcium is not all the calciums are good sources of calcium. Dicalcium phosphate is pretty good. Calcium gluconate when you talk of, calcium lactate when you talk of, when you use them orally, they bind to the phosphorus and convert into calcium phosphate. So excess of calcium led on to elimination of phosphorus. This we use in renal disorders when there is hyperphosphatemia. So excess of the calcium now leads on to a zinc deficiency, excess of calcium of gluconate, etc., lead on to hypophosphatemia, and also they have a bearing on the manganese as well to some extent. All these are required for the tendon. So in a growing dog, excess of calcium ends up in the gait of the animal, skeletal remodeling would occur. So the skeletal remodeling, when it is occurring, they go back and they get the calcium and phosphorus levels done by a biochemistry. They are either normal or high. They are never low. But many a times again people start using calcium injections, again calcium gluconate, because you don't get a dicalcium phosphate on that. So unfortunately what is happening is calcium balance. When you talk of, you should think in terms of what is the amount of calcium I get. Examples I can give you. If I use milk, 1 ml of milk will give you 1 milligram of calcium. But unfortunately, in the current day concept, many people would say don't give milk because lactose intolerance. 90% of the dogs are not lactose intolerant. 10% of the dogs are lactose intolerant. There you cannot give milk. Then what is the source of meat? Meat is a very poor source of calcium. Milk is a good source of calcium. Your cereals are a good source of calcium. So what you need to work out is what is the diet I'm using homemade and how much of calcium I'm getting it. So you need to balance it. If that is done, it's good enough. And if you are using a commercial diet and if you use a calcium extra, you are ending up in skeletal disorders.
Right, sir. The next question is, sir, could you throw some light on zinc acetate in case used for dermatosis?
Ideal is what I gave you as zinc sulfate rather than the acetate. That's a poorly available zinc. Zinc oxide, zinc acetate, they are all poor sources of zinc. Like what I gave you, methionine, zinc, and gluconate, and zinc sulfate. These are ideal. And that's why when you get these powders, you can get these powders and convert it. But unfortunately, there are preparations available, zinc. I didn't talk much about that. Many human preparations are available. But zinc, when given orally in a high concentration, produces nausea. And certain times you end up in vomiting. So many of the human preparations also end up in vomiting or nausea. So GI disorder you create and you give zinc, it is never absorbed. So you need to manage in such a way that zinc, you should make it palatable. If you make it palatable, then zinc absorption will be good and also intake will be good. Otherwise, any form of zinc cannot be given and you don't get a good source of that, and it is not easily bioavailable. Bioavailability is the criteria. Many times we think whatever I give is bioavailable, it's not so. Methionine, when you convert into that, is good. For example, calcium, people talk of chelated calcium. Chelated calcium is better absorbed. Similarly, strontium. Again, you get strontium in the form of a yeast. There are preparations. They take it as a dietary source of that by combining with a different mechanism and compound it to that. So zinc also is available as a tablet, not in India. It's available in the Western world, and the tablet can be crushed and given. And tablet is made more palatable on that. But unfortunately, none of the zinc preparations of veterinary brands are available in India.
Right, sir. So the next question comes from your ketoconazole therapy that you recommended. Could you please elaborate on ketoconazole therapy in PHA, duration and the dose?
Yeah, it is very similar to the dosage what we use for an antifungal infection, used at the rate of 10 mg per kg, 3 to 4 weeks, and remission would occur. But unfortunately, what would happen here is long-term therapy with ketoconazoles have a bearing on the liver function. So hepatotoxicity. So what you need to do is monitor the liver function, monitor the cortisol level, monitor the glucose levels as well, and then put on the treatment. But not all cases will respond, but initially, maybe unknowingly, sometimes you would have treated them and they respond. But when you have all the symptoms like what I gave you, like truncal alopecia with comedones being formed, thinning, they don't work. It doesn't work.
Sir, the last question from my end, and then I take it over to Dr. Nagaraj, is that which one, in your practice, in your clinical experience, which one is more effective, ivermectin or doromectin for dogs for treatment of ectoparasites?
See, I do visualize like this. From my point of the evolution of a drug, when we talk of, we started with ivermectins. Ivermectins is a group of compound. We started with ivermectin, then we moved on to doromectin, then on to moxidectin. So we have been going one after another. Going by the half-life of that, many times I would rather prefer a doromectin because it has got a little more, 70 extra than an ivermectin. In terms of an efficacy, there are variabilities, but I wouldn't come across people talking about, say, resistance because it is not an antibiotic, though people consider in certain classifications they also fit into a phenomena calling it as an antibiotic because it is produced by an organism. But resistance is not very high. But safety-wise, doromectin has got a longer half-life, and safety-wise, I haven't come across the reaction, so my choice is doromectin. But doesn't mean that I don't use ivermectin. I do use ivermectin. Given a choice, I would take doromectin in case of dogs. But whereas in case of cats, I would prefer a salamectin preparation because salamectins are much safer for cats than any of these.
Right, sir. I'll thank you on my behalf and take you to Dr. Nagaraj to sum it up. And
yes, thank you.
Yes, sir. Thank you. We are very blessed to have your lecture, and it is very you have given a very important issues whatever we are practicing in our clinic. So it is very useful, and we will follow whatever you have told. Thank you very much, sir. Please always be with us, sir. Thank you.
Thank you. Thank you very much. Thank you for the wonderful opportunity given to me. Thank you very much. And thank all the participants for their well-behaved way of the seminars being done in this. Thank you very much. Thank Intas again. And specifically thank Dr. Nagarajan for bringing me onto this forum as well. and hopefully the association would do a good job, and is very necessary, because I would always say dermatology is a breadwinner for small animal practitioners, and because there are no emergencies and cases are always in the increase, and a good way of good approach is necessary, because we should not fool people. That's what is very important on this. Simplest things can get complicated, complicated things can go in a simpler way, and I'm sure the association should flourish, and association will be able to do a good job for the benefit of practitioners as well as the our pets more particularly. Thank you very much.
Thanks. Thanks.
Thank Dr. Ravindra specifically, because he helped me a lot yesterday in organizing my presentations, and also thank Dr. Amjot Singh for being part of this program. Thank you very much.
Thank you.
So I'll take now liberty of leaving. Thank you very much.
Yeah, thank you to everyone, sir. We are closing the session. Thank you.
Okay.
Thank you.